Hello.
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 Welcome. Hello. Can you hear me?
Yes.
Yes.
Hello, Pawan sir, join.
Yeah.
Should we start now?
Yeah, just ask Dr. Pawan sir.
Hi, Pawan sir.
Yes,
Good afternoon.
Hello, Pawan sir.
Sir is not joined yet.
No, he has already joined, but I think there is some problem with
Yeah.
audio. Sujit, can you call him?
Yes, 1 minute.
Yeah. Dr. Girish sir? Dr. Daga sir? Daga sir?
I think Daga sir is not here.
Ask them to make you host now because...
Hello, Priyanka.
Yeah.
Hello, Priyanka.
Yeah.
Hello.
Yeah, I can
Hello.
hear you. I can hear you.
WhatsApp the link on ma'am's number.
Okay, just a minute. Just a minute and call Dr. Daga sir now to make you host.
Okay, first forward the this link.
मोबाईल द्या काय सुचून सांगते कधी खेळतच नाही का मोबाईल पुरस्कार कधी केलं जात आहे का काय असं वाटतं अशी परिस्थिती
Hello, Suchi.
Hello.
Hello. I have assigned you as a host.
Yes.
Just I had.
Make him host.
Just I had. No. Already I was host, but just I changed my device. So you can make me again host. I opened Zoom link in another device. That's why I have to make some another person as a host.
All participants, keep muted yourself. Dr. Shailendra,
Yes, yes, madam.
now you can start.
No, we are starting with the introduction of the Pawan sir, but he is not joined. No? Hello.
Hello.
We are starting with the introduction of the Pawan sir, but he is not joined yet.
Okay.
We have to wait for a while.
Yeah, no problem. I'm getting some problem with the network, I think.
Yeah, maybe. First, we have to check his presentation also. Hello, Pawan sir. Good evening.
Hello, Pawan sir.
I think he is unable to hear us. Have you called him? Sujit?
Yes, now I can.
Okay.
Now we can see you.
Sir, please. Sir,
Finally.
check your
Good evening.
Good evening. Please check your presentation, sir. Whether it is coming on whiteboard or not.
Should we start?
Yes, sir. Absolutely.
Okay. Good evening, all. Today we are starting with another webinar after the grand success of our Shushruti held at Nagpur. So today we are dealing with a basic of any surgery, that is anatomy, and Dr. Pawan sir is a very master in the anatomy and surgical, basically advanced surgical anatomy. Without knowing anatomy, we cannot be a better surgeon. So today we are starting from the basic to the advanced anatomical and surgical orientations. In short, I am introducing the Dr. Pawan Gulani. He is the Medigrace Hospital working at Nagpur and Inaya IVF Center. He is a consultant laparoscopic, pelvic and gynec oncosurgeon. Director at Medigrace Hospital, Nagpur. Director at Inaya IVF and Fertility Care. Visiting surgeon at prominent hospital in and around the Nagpur. His work experience is very vast. Operated more than 12,000 vaginal hysterectomies, more than 5,500 laparoscopic hysterectomies, and more than 100 laparoscopic radical hysterectomies. Laparoscopically managed more than 1,500 patients with severe endometriosis, which we find very difficult to operate on the endometriosis. He is the best person for endometriosis. His special interest in exploring new possibilities in fertility preserving endoscopies, sharing knowledge and promoting laparoscopic surgeries. Other than this, he is a very good teacher. He has very good experience in teaching in his short span of career. He is becoming one of the most leading practitioner at Nagpur. So, not wasting much time, I am hand over to all Dr. Pawan sir.
Thank you so much, Sujit sir, for the elaborate.
One line introduction from my side. I just want to say he is a very dynamic personality I have ever met in my life. And I am very much proud to say that he is my guru and my idol too. So welcome, sir, to NEMA OBGY platform. And
Thank
it's
you,
our we are lucky to have you on this platform. Thank you so much. Please continue.
Thank you so much for inviting me. I think there is some problem at our end. We lost the electricity, but still what we can do is I am going to have this presentation in two parts. One is going to be a PPT presentation and another is I'm going to describe the pelvic anatomy in on the blackboard by showing you all the diagrammatical orientation of everything that we generally see while doing the while learning the anatomy basically. So now, pelvic anatomy, it is one of the most important thing. All the gynecologists right now in front of us are will accept that without knowing the anatomy, you cannot proceed in the pelvic surgeries. Anatomy is like a basic. Without knowing numbers, you cannot do calculations. It is just like that. So this is the nap time probably for the most of you from Medigrace Hospital and NIVF to a wonderful world of pelvis. Okay. So do we really need to know the pelvis, pelvic anatomy? Of course, there is no doubt. And if you want to operate the pelvis, anything in the pelvis, right from the ovarian cyst to hysterectomies to endometriosis to anything, you need to know the anatomy thoroughly. Do we have any options? Obviously, we don't have. And how difficult is it? See, pelvic anatomy is one of the most easiest anatomy that anybody would learn. So in my opinion, it is absolutely easy to learn the anatomy. Hello, am I audible?
Yeah, you are audible, sir. Please
Yes.
continue.
Yes. So the anatomy of any anatomy is to know about the organ structure. Basically, in surgery, the practical application of this science is to treat the disease and remove the tumor simply by minimizing the symptomatology and improve the functions and the quality of the life. See, minimally invasive surgery has an additional advantage. See, laparoscopy is not just minimally invasive, but it also gives you a magnified view. Magnified view with good illumination. Then that means the laparoscopy is the ideal technique for learning anatomy in deep-rooted areas of the body, and most importantly, the pelvic anatomy. If you want to operate a gynec anatomy, if you want to operate the gynec surgery, you must know the pelvic anatomy and to reduce the rate of complications. See, now the pelvis is not a 2D structure. We all know the pelvis. We have always been taught that pelvis is a 3D structure. It is actually a basin. That the basin, wash basin that we have, it is exactly simulates that, because in wash basin you have about borders, then there is a dipping cavity inside, and there is going to be an outlet, and the pelvis exactly depicts like that. So if you allow me to change the direction of my laptop, can you see the whiteboard, everybody? Excuse me, can you see the whiteboard?
Yeah, we can see the
Yes,
whiteboard.
we can see.
Yes. So 2D structure is something like this. You have a straight line. Is it visible?
Yeah, sir.
3D structure is something like this. You understand?
Yeah.
It has a depth. You understand? Whenever we see any structure, whenever we doing laparoscopic procedures, and whenever we see any book, whatever we see in front of us is 2D. But in pelvis, it is totally different. It is a 3D anatomy that we have to deal with, and the best way to know that is doing the 3D laparoscopy. Okay. The picture is small. The outside picture, the board picture. Can we make it larger?
Hello, sir. You have to show like it. We can see, we can understand. Just go ahead, sir.
Yeah. So whenever we enter inside the pelvis, what happens? Whenever you are doing laparoscopies, you enter inside the cervix, you see a structure that is called sacral promontory. Because we are entering at the umbilicus or above the umbilicus, so the first structure in the pelvis, if we suppose remove the bowel, rectum away from the area, the first structure that you see is the sacral promontory. Okay, and beyond that sacral promontory, it is going to dip down and form a basin. Okay, because this is the entry point of the pelvis. Then you have the sacral 𝙦 on both the sides. These are the 𝙦 of the sacrum. Okay, sacrum is going to be like this, right? Then you are going to have the pubic crest on both the side.
So we cannot see that, what you are showing. Can everybody see what sir is doing?
Yeah, we are able to see.
Hello. Just make
Hello.
zoom of window of Pawan, sir. You will
Yes,
get the
sir.
picture.
I will stop sharing this slide. Then probably you'll be able to see the yes.
Yeah. Now we
The
can.
vaccine.
Yeah.
Actually, there is some problem with the light here.
No, I just.
But
So
we are
that-
able to see, sir.
Yeah, perfect. So you have this 𝙦 of the sacri. You have the sacral promontory. You have this 𝙦 of sacri. Then you have the pectineal line, and you have the pubic symphysis in front, right? This is how the pelvis is. Okay. Everybody is getting it?
Yes, sir.
Yes, yes.
Perfect. Perfect. So here what happens? From here, you are going to have mesentery of the sigmoid colon. This is actually on my side because it is the camera. We are having the laptop camera. It is a selfie camera. So probably if you see, it is rectum is coming on the opposite side for you. It like this. Are you getting it now? Because
Yeah.
this is the rectum, this is the mesentery, and this rectum, it falls here. It is going to obliterate your vision. So I am going to remove this rectum along with the mesentery. Understood?
Yes.
On the sacral 𝙦, if you see, it is going to look something like this. Obviously, the depth is going to be deeper, but it is going to look something like this, and you are going to see the coccyx here. Okay? You have the false pelvis here, right? This is anterior superior iliac spine. This is posterior superior iliac spine.
Yes.
And you are going to have your vertebrae here. So what now we have in the pelvis, when we start seeing the pelvis and dissecting the pelvis, we have this muscles that is called as a psoas muscle that originates from the lumbar vertebra. It crosses the pelvic brim and enters into the femoral canal. Are you getting it?
Yes,
Yes.
yes, sir.
Yes. So, because this psoas is absolutely important whenever you are doing any pelvic dissections. Understood? If you don't know psoas, then it is very difficult to identify the structure those are going to lie there. Now, at the level of L1 vertebra, we are going to have a division of the aorta. Okay? And this aorta is going to come at the level of the sacral promontory, and it is going to form two major vessels. We all know it, and that is the external iliac vessel here and the internal iliac vessel. Right?
Yeah.
So when we enter inside the abdomen, the first thing we see is the sacral promontory, sacral 𝙦, and these two major vasculatures. Right?
Yeah.
On these two vessels, we have two more things, and very important things that most of the time gynecologists are actually scared of, and that is a ureter. You understand? Ureter comes lateral to the vessel at the level of the brim. It goes medial. It goes medial like this. I'm sorry, I'll just redraw it. It goes medial like this. And here, this vessel, that is internal iliac vessel, is going to lie lateral to the ureter. Is it visible?
Yeah, it's visible.
Yeah, it is
Yes.
absolutely visible. Just go ahead.
Okay. Yes. So now I'm for just to explain you the vascularity of the pelvis, I'm just going to remove this ureter for some time. Okay. Right?
Yeah.
Here there is one more structure that we have, and that is the nerve. You have this nerve that is going to run on the psoas muscle along the vessels. Sometimes this nerve can have can have two roots or one root. It is a genitofemoral nerve. If suppose it divides before this angle, you can see a road double track appearance. It is like a road, your railroad appearance. If suppose it divides a little beyond, then it is going to be intact nerve that you can see. But most of the time you see dual nerves. One, the above branch is going to be a genital branch, and the branch that goes along the femoral artery, it is a femoral branch. So it is a genitofemoral nerve. So once you start dissecting, first thing you are going to see a genital femoral nerve, then you are going to see the external iliac artery, then probably you will see the ureter and the internal iliac artery. Is it clear till now?
Yes, sir.
Yes.
Perfect. On a medial to this common iliac artery, you are going to see a band of nerves here on both the sides. Right? And these band of nerves are nothing but the superior hypogastric plexus. From here, it is going to go down because the sympathetic supply of this superior hypogastric plexus is drawn from the lumbar L1 to L4. And from here, it goes down here in the pararectal space, also called as Okabayashi space, where it draws its parasympathetic supply from L2, L3, L4, right? And then here at the level of base of the bladder, it is going to form something that is called as inferior hypogastric plexus. Okay?
Yes.
Perfect. So now, I hope we are clear what we are going to see at the level of the pelvic entry. At pelvic entry, we see the sacral promontory, sacral ala. On the sacral ala, we see the vessels, we see the ureter. And one more important thing that we see, we have not drawn it here, but it is going to be an IP ligament that is going to lie exactly above this, everything. And it is going to cross like this on both the sides. Right? This IP ligament is nothing but the ovarian artery and the ovarian veins. Right?
Yes.
Now let's know more about the internal iliac artery system. Okay. See, external iliac and internal iliac, these are two major vessels that we see. See what happens embryologically. This is sacral promontory. Okay. What happens embryologically? The main vessel that supplies or that carries the blood from the fetus to the placenta is the artery, right? But it is a metaphor that we have in the embryological life, because in embryological life, the artery carries the deoxygenated blood. We all know that, right? So in embryological life, what happens? This vessel is dominant. On both the sides, you are going to have this internal iliac artery that continues to the obliterated umbilical artery. This obliterated umbilical artery that you see is a postnatal phenomenon, right? In prenatal phenomena, when baby is inside the womb, this is the dominant vessel, because this vessel has a precise job of carrying deoxygenated blood to the placenta. So the entire blood is going to be carried by only these two vessels, the internal iliac vessel. You understand? But what happens in embryology, a post-embryological life, this vessel undergoes obliteration, right?
Yeah.
So what is this vessel? It is an obliterated umbilical artery, right?
Yeah.
But this here it is very difficult to show because the obliterated umbilical artery is going to be somewhere like this.
Yeah.
You understand? It climbs
Yes.
on the abdominal wall, and on both the sides it forms a triangle, perfect triangle, and it runs towards the umbilicus. You understand?
Yeah.
So both the sides obliterated umbilical artery is going to be like this. But what happens in embryological life when your uterus, your rectum, the ovaries, all these structures are not developed. But slowly, as your life progresses postnatally, these structures are going to develop. So this, you have a bladder here somewhere, you have a uterus. So what is going to happen? This obliterated umbilical artery, this internal iliac artery. First of all, I'll tell you how it divides. Basically, this internal iliac artery gets a first division, that is a posterior division. Can you see this division? It is medial and posterior. It pierces the sacral fascia here. This is entirely lined by the sacral fascia, and it goes inside to give a superior gluteal artery. The significance of telling you this posterior branch, posterior division of the internal iliac artery is, by ligating the internal iliac artery during PPH, you ligate the internal iliac artery beyond this posterior branch. Because if you ligate it above this posterior division, there is a possibility that because of the your obliteration of the superior gluteal artery, you'll have gluteal claudications. You understand?
Yeah.
So that's why you need to spare this artery, and to spare this artery, you have to keep a distance of 3 centimeters from the division of internal iliac, from the division of external internal iliac artery. From this division, you have to ligate the internal iliac artery at least 3 centimeters away, so that automatically, obviously, in each case, you cannot dissect this because it is actually a posterior branch. It goes like this, posterior, inside the board. Okay, so to simplify the things, take a distance of 3 centimeters and then ligate the internal iliac artery. You understood the point?
Yes.
Yes. So next is the branch that is going to go lateral. This is the obturator artery. Okay, this is here it is going to be a vein. You understand? Can you see? Just exactly next to the artery, you are going to have this vein, right? Below this vein is going to be a obturator fossa. This obturator artery goes inside the obturator fossa. Then in accompanying with the obturator nerve, it exits the pelvis. Okay, it has an obturator vein also, obturator nerve and obturator artery. I'm going to show you the videos where you can see all these things clearly. Okay, then one more important and significant branch that we see, that is a medial branch, that is your favorite uterine artery. Okay, it is one tortuous branch of the internal iliac artery, and it is tortuous because we all know uterus is a distensible organ during pregnancy, so it has to be tortuous. You understand? So it goes medially, and from there it climbs up. So it is, uterus is going to lie somewhere like this, and the vessel is going to come somewhat like this. So it is going to go on the posterior lateral wall of the uterus. So it is going to go medially and then going to climb up. Okay. So
Okay.
significance of this vessel is it divides the paravesical and the pararectal space. Okay.
Yeah.
Understood?
Yes.
Next, we have posterior branches. These posterior branches are like this: the inferior gluteal artery, the middle rectal artery, and one more significant branch that comes posteriorly is pudendal artery. Pudendal artery is very important because pudendal artery later on divides into the vaginal branch. It can also divide into inferior vesical branch also. Okay, and pudendal artery is the one artery that supplies to the entire perineum. That's why it is a big artery. Okay, so if you want to save yourself, don't injure this vessel particularly, because it is in the depth first of all, and also it is very big lumen. So whenever you have a big lumen vessel, you can have a difficulty in coagulating it because it is bigger than the uterine artery lumen. You understand?
Yes.
So these are the vessels of the posterior division. I told you there is one more vessel that is left, and that is the vesical artery. It comes from here. Sometimes it can come from the division between the your uterine artery and the obliterated umbilical artery. But sometimes what happens that this obliterated umbilical artery is patent till certain distance, and from there you are going to have your vesical branch. Okay, from both the sides. So whenever you are doing radical hysterectomy, you have to be careful. Avoid damage to the vesical artery. Even if you injure vesical artery, it generally does not cause any problem. Basically, in pelvis, even if you injure anything, it does not cause any problem because the collateral system in the pelvis is so nice that generally the collateral happens and the organ is not going to undergo any necrosis. Understand?
Yes.
So we have covered all the branches of the internal iliac artery. One more thing I would like to tell you about the uterine artery specifically. When you see in the HD imaging, the uterine artery is going to be little bluish tinge at the origin. Okay, so that thing has that thing gives you a peculiar identification feature of the uterine artery into the deep pelvis.
So any specific reason why it looks blue?
Mostly it is because it is thin.
Okay.
Yeah, and it is associated with the vein. The superior uterine vein is very in close proximation to the uterine artery.
Okay.
Okay.
Yeah.
Now, since we are done with this, okay, so I am going to be removing the internal iliac artery system, okay, so that it becomes a little clear for us. Now the external iliac system, okay. So we all know external iliac arteries are not very significant as far as the gynecologists are concerned, but it still gives two vessels inside the pelvis. Okay, one vessel is going to be a circumflex vessel. Okay, it supplies the iliacus muscle. It has a iliacus muscle on the false pelvis because these are the blades of the ilium. Okay, and one more important vessel that comes from the superior surface of the external iliac artery, that is inferior epigastric artery. It originates just before this vessel goes inside this structure. This is inguinal ligament. Understand?
Yes.
So it originates from the external iliac artery just before the inguinal ligament. That's why it does not take part in the subcutaneous tissue. That's why it passes below the muscles. You understand?
Yeah.
And what is the significance of knowing this vessel? This vessel runs exactly in the midpoint of the spino-umbilical line. So whenever you are taking a trocar entry in the laparoscopy, and if you injure this vessel, because this vessel is something in even the average weight patient, you won't be able to see it on trans illumination. And if you injure this vessel, what is going to happen? We are going to have a big hematoma in the abdominal wall. Understood?
Yes.
So,
yeah.
And this entire thing, I told you the psoas. This psoas runs, psoas and iliacus runs here, forms the bed of this femoral canal. This actually is the femoral canal, this place. Okay? From this place, you are going to have the femoral vein. You are going to have the femoral artery, and you are going to have this femoral nerve that is going inside this. We have all seen this femoral canal in surgical lectures or surgical tutorials. Okay. So this also I'm going to show you on the video. Base of this femoral canal is formed by the psoas muscle. Okay. One more important thing that happens here. Is this, the pectineal line. Can you see this pectineal line?
Yeah.
Right?
Yes.
This pectineal line will come something like this. Pectineal line is going to come down, and your vessels are going to be on the false pelvis side. This is going to be your vein, right? So whenever you try to take or do the pectopexy for the patient, this pectineal ligament is nothing but the thickening of the pectineal line, where you can actually fix the mesh for pectopexy from one side uterus and to the other side. Okay, and for that you need to know the vicinity of the iliac vein to the pectineal ligament, because sometimes here you are going to have this, here you are going to have your obliterated umbilical artery, right? It is going to go inside and come out because it is perpendicular like this. Okay, and a round ligament that comes is going to go, actually in this it is very difficult to show, but round ligament is going to cross and reach here. So whenever you are dissecting the pectineal ligament, you have to dissect the obliterated umbilical artery to the medial. You have to pull this obliterated umbilical artery here so that you can see this point here, where you can fix the mesh. And when you are taking a bite through the pectineal ligament, this vessel is very close. So you need to know the vicinity of the pectineal ligament to the external iliac vein. There is one more important or not so important structure that lies here, is the connection between the internal iliac vein. Internal iliac vein is going to be here, external iliac vein is going to be here. A connection is there between these two systems, and that is called as corona mortis. Okay, you eventually, whenever you are doing pectopexy, you can see this connection. Earlier they used to think that injury to the corona mortis can be fatal, but actually it is not the case. You can actually coagulate to corona mortis, and it is just behaves like any other normal vein. You can coagulate and cut the corona mortis. It does not cause any problem. Okay.
Yes.
Yeah. So I think we are done with the internal and external vascular pedicles and the arteries, and the veins are obviously going to accompany everything is going to accompany with this. I just want to show you one thing, and that is this vessel. I told you this vessel is the internal iliac artery. You are going to have the uterine artery here, right? This is the uterus, right? And this is the cervix. So what happens? Your ureter is going to lie medial to the internal iliac artery and go straight past the midline to reach the bladder, right? Understood? But what happens during this? Your uterine artery is going to cross it above. So it forms the water under the bridge. Okay? Understood?
Yeah.
And here you are going to have one more thing. Is going to be your inferior hypogastric plexus. Right?
Yes.
What happens here? I told you the uterine artery and uterine veins are going to, the superior uterine vein is going to go accompany with each other. So it crosses above the ureter. Actually, this is not a problem. The problem is inferior uterine vein. This is the pudendal vein that is going to come like this. This inferior, it is going to join, and later it forms the internal oblique vein. Here what happens, below the ureter, whatever the cuff of the vagina and the part of the cervix, it forms an inferior vein or inferior uterine vein. This inferior uterine vein sometimes during radical hysterectomy can bleed. Okay, and if you don't lateralize this ureter and you coagulate that internal your inferior uterine vein, there is a possibility that you might injure the ureter also and hypogastric plexus also, inferior hypogastric plexus. So when you are dissecting the deep uterine veins, you have to lateralize the ureter first. You have to identify the inferior hypogastric plexus first, And after identifying all these structures, you lateralize them, separate them, and then only try to coagulate the structure where it is bleeding from. Because the deep uterine vein are supposed to be notorious, and there are higher chances that he might bleed. Okay? Are we clear to this till here?
Yes, yes.
Perfect. So now, I suppose the vessels we have covered. Anybody, if anybody has any questions till now? You can ask. Right?
Yeah.
So now see, we have covered the vasculature. I have told you about the nerves.
Sir, can you cover with this sacral promontory with the sacral veins and the
Yes.
superior hypogastric plexus?
Yes. See, the sacral promontory is going to be like this. The ala of the sacrum is going to be like this, right?
Yes.
Actually, there are going to be three sacral vessels here, right? 2 arteries and midline vein. Okay.
Okay.
And the superior hypogastric plexus somehow comes little up here. Once you hold the rectum and lift it, the inferior hypogastric plexus goes along with that because it is lying inside the fat of the rectal mesentery. It is very close proximation with that.
What precaution we should take during the sacrocolpopexy?
Sorry?
What precaution we should take when anchoring the stitch or a mace?
Whenever you are doing sacrocolpopexy, you have the peritoneum like this, or somewhere like this, right?
Okay.
Ureter is going to be here, so you give an incision here between the mesentery and the ureter. Hold this and lift it up. So this entire thing is lifted up, right?
Okay.
You have the sacral, on the sacral promontory, you have this anterior longitudinal ligament.
Yes.
You take a bite through it. There is a possibility that the vein might get injured while taking the bite, or the artery might get injured, but then you can safely coagulate it. There is no problem.
Okay.
Okay?
Yeah.
Yes. So now we are going little deeper. I'm just going to tell you about the fascia, and then we'll go towards the muscles. Okay?
Okay.
So this is actually the abdominal wall. This is the xiphisternum. Okay? You are going to have, this is the false pelvis. This is the true pelvis. I hope everybody is understanding this. And
Yeah.
you are going to have a spine here. This is just the pictorial diagram. Okay. Okay.
Yeah.
Now, what we have here is a muscle. See, believe me, every muscle in the body is covered with the fascia. Every muscle, because it has to keep the integrity of the muscle so that it acts efficiently. That's why it is covered with the fascia. Understand? But the advantage of this fascia is this fascia also provides support to the other structures. That is the additional advantage of the fascia. So this is the transverse abdominis muscle. On transverse abdominis muscle, you have inside, you have this transversalis fascia. The entire abdomen above the peritoneum is lined by the transversalis fascia. We all know that, right?
Yes.
This transversalis fascia is connected to the fascia iliaca. It is a fascia that is covering the iliacus muscle on the iliac bone. Okay? Right? Then you have, not vertical. Then you have Yes. This iliac muscle is done. Then you have something that is called as obturator internus muscle, right?
Yeah.
And the fascia that is covering the obturator internus is called as the pelvic fascia, right?
Yes.
But here we have a perineal membrane also, or perineal muscles, levator ani. It goes like this. I told you it is not a straight structure. It is going to be like this. Understood? Like a basin. Because it has to contract. If it is like this, how can it contract, right? If it has a length, the perineal membrane, it can contract and lift the structure up. Are you understanding my hand movements? I'm sorry, I will show you. See, if it is like this, it can contract. If it is already like this, how can it contract?
Yeah.
So it
We
has
can
to
call
be
it
like this.
pelvic diaphragm also.
Yes. So it has to be like this. So it is in the angle. It is always in the angle. So the fascia that is covering this muscle is a you can say a medial pelvic fascia or arcus tendinous fascia pelvis. Now we always know what is white line. We always have heard about white line, right? So what do we call white line? This place, if it entirely runs around the obturator bone on the posterior side, and this pelvic fascia, the arcus tendinous fascia pelvis attaches here, this point. Are you understanding?
Yes, sir. Yes.
Yes. So this is the white line because it is 2-dimensional. It is going to be round like this, right? This is arcus tendinous levator ani. This one. And here your organs are going to stay here. Are you getting it?
Yes.
Right? So actually this seems very nice and very easy to understand. But one thing you have to know, this pelvis organs, when it is placed, they are not placed straight. Why? What do I mean by that? Your sacrum is like this. Shall I delete or let it be there? We'll keep it like this. Okay?
Keep
We are
it.
going to have a sacrum. This is the coccyx, right? You have a symphysis pubis here. Here there is something that is called as levator plate.
Yeah.
Posterior to the rectum. Your rectum is going to come down like this. Like this. It is going to lie flat here. Right? And then it is going to turn. So this is the anorectal angle. This angle. We all know this. Understood?
Yes. Yes.
Are you getting it?
Yes, sir.
Yes. Now, sorry, it is gone little deep. I'll just draw it a little smaller. Right? Next is vagina. It is going to be flat like this. And you are going to have the cervix and the uterus that is anteverted and anteflexed. Are you getting it?
Yes, sir.
Beyond that, we have this flat urethra where you have this bladder like this.
Yes.
Are you getting the anatomy?
Yeah, sir.
Yes.
This is actually the anatomy. What you see here is different because it is a coronal section and it is just made to understand. Actually, the organ lies like this. So whenever the pressure is coming from the abdomen, the entire pressure is borne to this place, and that's why it has to be very strong. levator plate. It is a part of complex pelvic fascia system. Now, if I tell you this fascia, they are going to lie absolutely perpendicular to each other, parallel to each other. Can you see this?
Yes.
And it forms a connection in between to cover. They are just like pockets. मतलब if you have seen a toothbrush का पैकेट ना, जो होटल्स वगैरह में मिलते हैं, जैसे टूथब्रश का पैकेट रहता है उसके अंदर टूथब्रश रहता है. So these two are fascias. They are connected to each other at this point, and from there this fascia is going to connect and get attached to the white line here. Getting it?
Yeah.
And this fascia, the anterior fascia, is going to be the pubocervical fascia. The posterior to the vagina is going to be a Denon-Villers fascia, and posterior to rectum is going to be levator plate and Walder's fascia. Understood?
Yeah.
Yes.
Now, whenever you see a support system of any organ, let's say the bladder or the uterus, the most important support structure of the uterus is this ligament. It is uterosacral ligament. You understand? The uterosacral ligaments get attached pararectally as a thickening of this fascia. It is a thickening of the facial system that supports the cervix from getting forced through the hilum. Can you understand? That's why they say the uterosacral ligament is exactly in the straight line to the apex of the uterus.
Yes.
Understood?
Yeah.
Actually, sir, this is a pelvic diaphragm. It is formed when Homo sapien become erect.
Yes,
Later on, it was not there. It developed when a human become erect, upright. Is it correct or?
Sir, the pelvic diaphragm was already there because even the other mammals do give birth to the babies, but
but especially in humans.
I understand. Yes, but what I understand, this diaphragm has become more rigid. The levator plate has become more rigid after the time we started having an erect posture.
Okay.
Yes. So the concept is everything is flat, everything is just flat, covering each other. You understand?
Yes.
So whenever you have defect in the uterosacral ligament, this support is gone. What is going to happen? The cervix is going to go down because these two fascia are intact. Understood?
Yes.
Whenever you have defect in the pubocervical fascia, the bladder is going to come down. Whenever you have defect in the Denon-Villers fascia, the rectum is going to come out. It is so easy to understand if you know the pelvic facial anatomy properly. I hope it is clear now.
Yes, sir.
Yes.
Yes, sir. Yeah.
So one more thing that is important in the fascia is whenever you have this pubocervical fascia, you are going to have a cervix here, right? You are going to have your bladder fascia somewhat like this. This is the brim, right? This is the cervix I have drawn, right? This is the paracervical ring that is there. And this is where the bladder was supposed to be. So it is a pubocervical fascia. I have removed the bladder from here, right?
Yes.
The lateral edge of this pubocervical fascia is the pubocervical ligament. And pubocervical ligament के ऊपर से यहाँ पे यूरेटर जाएगा अंदर. Getting it?
Yes.
Right?
Yes, sir.
Yes. So when you are dissecting the levator, your ureter for lateralization, you have the thickness of the fascia that is lateral. That is a 𝘾𝙁 ligament. We say the ureter is the part of 𝘾𝙁, the fibers of the 𝘾𝙁, it goes through the 𝘾𝙁 ligament and that form the ureter tunnel. So the part of that is this pubocervical fascia, pubocervical ligament also. So when you dissect the roof, your pubocervical ligament becomes bare. Obviously the upper fibers of the pubocervical ligament will be removed, and it becomes the separation of the ureter becomes easier laterally, because of this fascia it is attached to one place. Whenever we do the ureteric tunnel dissection, if you put the instrument inside, you can feel the resistance all around it. That's why it is called tunnel, right?
Yes.
So this tunnel is formed by these fibers of this ligament and the 𝘾𝙁 ligament. Okay? And posteriorly, this cervical ring is going to have your uterosacral ligaments. Actually, these uterosacral ligaments are like this. They are perpendicular to it, so that it can hold the vagina and the cervix up. And it is a dynamic support. The pubocervical, the sacrospinous ligament. Uterosacral ligament. I'm sorry. Okay.
Okay.
So this fascia till now is clear here.
Yes.
So one more thing I would like to add. Recently we did a case of descending perineal syndrome where the 𝙊𝘼𝙑 fascia was defective. So I'll just go back to the previous diagram. The sacrum, the levator plate, right? The rectum, the anorectal angle. Okay. What happens whenever you have defect? This is the 𝙊𝘑 fascia that is actually holding the rectum at its place. Otherwise, what would happen? Because of the nature, because rectum is loaded with the feces, it can fall in front. Okay. Suppose this 𝙊𝘑 fascia is defective, what is going to happen? This rectum will not be attached here and it will come like this. Are you getting it? So the angle that was supposed to be like this has been disturbed. And also it has an outpouching down because there is no support here. So this anorectal angle is totally distorted and the rectum is going to come anteriorly. So what? Whenever there is a pressure that is coming, for feces, this rectal mucosa prolapses. Somewhat like this. In later stages, it is called anorectal intussusception or rectorectal intussusception. I hope it is clear.
Yes.
Priyanka ma'am?
Yes, sir.
Yeah.
Yes. So what we do, we put a mesh here completely on the perineum and tie it to the sacral promontory so that it forms the artificial fascia behind the rectum. So that the anorectal angle is formed again and the rectum has good support posteriorly. Right?
Right.
So now, once we are done with the facial things.
What are the causes of DPS, sir, mostly?
See, DPS is actually the innate deficiency of the fascia.
Okay.
It is not necessary innate deficiency of the 𝙊𝘑 fascia.
Acha.
It is not necessary is going to happen because of the childbirth or labor or anything like that. Because childbirth or labor is going to affect the perineal membrane or the pelvic floor.
Yeah.
Right?
Yeah.
So it is not going to affect the 𝙊𝘑 fascia. That is totally outside the concern of the your childbirth. Okay.
Yeah.
Okay. So now we are done with the The fascia, we are done with. Now next comes is, this is the pelvis, right? This is the sacral promontory. This is the pubic symphysis. Okay. Now you are going to have muscles of the levator ani. Okay, and they have the levator ani muscle. They are having a perineal body here, and every muscle is going to come like this. Obviously, there are division of the. This is the sacrospinous ligament. The way I told you, the spine is going to be somewhere here. So this forms the sacrospinous ligament here, right?
Yes.
So whenever I hope Dr. Sujit must realize that whenever we are doing sacrospinous fixation vaginally,
Yeah.
we see the sacroiliac muscle,
Yes.
𝙋𝙀𝙑𝙑𝙗𝘃 muscle,
Yeah.
right? The 𝙋𝙀𝙑𝙗𝙃 muscle is a spongy muscle, and beyond that you are going to have a sacrospinous ligament.
Yeah.
Right? Sacrospinous ligament is a strong ligament that actually holds the entire pelvic floor from one side. It is like a strong string that is tied so that this entire tent of the pelvic floor does not fall down. That's why it has to be very strong.
Yeah.
Okay.
Yeah.
Yes.
Sir.
So hello. Okay. So
Okay.
this pelvic muscles, I told you it is like a basin. It is like this. Okay, it fits like this. So whenever there is pressure from the abdomen, it tries to contract to counter the pressure. Okay, and while doing so, if you see the orientation of this pelvic muscle, they are coming from the anterior and getting attached posteriorly. So
Yes.
whenever this muscle contracts, what happens? It increases the anorectal angle. So it helps in the function of defecation also. Okay, because every pelvic organ is going to proceed anteriorly. You understand, na? Because this is going to be a sacrum here. So whenever it contracts, everything is going to go anteriorly.
Yes.
Okay. So even this anorectal angle that it is supporting, suppose if this is the anorectal angle and this is the pelvic floor, this is the pelvic floor muscles. So and this is anterior. So whenever it contracts, what is going to happen? Everything is going to move in this direction. Right?
Right.
Yeah.
So this angle is again going to become more acute and patient will not be able to defecate. This is actually a sympathetic response.
Yeah.
Yeah.
Okay. And when there is a parasympathetic response, these perineal muscles undergo relaxation and then defecation can happen. This is the significance of the pelvic muscles. Okay.
Yes.
Okay.
Apart from this, you have this obturator muscle that is going to lie laterally in the obturator fossa where you do the lymph node dissections and everything. Okay. Now the one more important thing that we have not covered till now is the okay. So I am again going to show you share with you the presentation that I was going through, and I will tell you about the spaces, pelvic spaces. Okay. So we have already covered these bony landmarks and everything. We are not going to go in that. Bone muscle vasculature, yes. Sacral promontory we have covered. Okay, so this is the picture that is going to. I hope everybody can see it.
Yes.
Yes. Beautiful.
Yes. So this is the structure that shows you on the right side You can see. Can you see the probably the pointer inside on the screen?
Yes, yes, yes.
Yes.
Yes, absolutely.
Move.
This is the area of sacral promontory I was talking about. Understood?
Yes. Yeah.
And from here you are going to have your superior 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 hypogastric plexus. This is the line.
Yeah.
Okay.
Okay. Here
Okay.
you are going to have the ureter that is crossing.
Yeah.
This is the external iliac artery. This is the external iliac vein, and this is the obliterator umbilical artery. This is the obturator
Yeah.
nerve. The dissected
Iliopteral
vein-
nerve.
Yes. The pectineal line again. You can see in this image. The
Yes.
line will be clearer to you, and this is the sacrospinous ligament that is posterior. This is
Yes.
the pectineal line that is lying the true pelvis, the boundary of the true pelvis. Okay.
Yes.
And you see the inguinal ligament also, or the lacrimal ligament. Now this is the a video that will show you the dissection of the pectineal ligament. Okay. This
Okay.
is the obliterator umbilical artery vertically. Can you make out this
No,
one?
it's not.
If you pull it
It's not
medially,
playing.
there is
Yeah,
going
yeah,
to be
yeah.
this entire structure
Now.
going to expose. Okay. This is the round ligament. Okay. So in between, this is the, if you realize this is the round ligament, this is
Yes.
the area that I was talking about. Can you see? This is the artery,
Yeah.
the external iliac artery. You can see this obliterator inferior epigastric artery that is originating, and this portion is the inguinal ligament. Can you see? This is the inferior epigastric vessel, circumflex vessel, and this is the inguinal ligament. This portion is the inguinal ligament. Okay, and this is the femoral canal. This area where it is going inside the below the inguinal ligament. Okay. You can see the inguinal ligament. I told you the inferior epigastric artery originates before the inguinal ligament, and that's why it goes anteriorly. It goes below the muscles,
Below them.
because muscles are, the inguinal ligament is nothing but the that is the end of your rectus abdominis muscle, right? So it goes below the muscles. Okay, and somewhere here below, you see the pectineal ligament,
Yeah. Yeah. Yeah.
right?
Yeah.
This area,
Yeah.
hard bony area, is a pectineal ligament. You can see how close it is.
Yes.
How close it is from the external iliac vein.
Yeah.
Can you make out?
Bluish. Yes. Very nice.
Yes. Again, the same image, similar image. This is the external iliac
Corona mortis.
pectineal ligament.
No, it's far away. Corona mortis is far away.
Yeah.
It is going to come here somewhere. If I dissect it further on this side,
Yeah.
it is going to come. See, corona mortis is something that you are not going to see always. Like, there is a possibility that you might not
Yeah,
see the
yes,
corona
yes,
mortis.
yes.
There is a possibility. Muscles we have already discussed. See, this is the image that I wanted to show you. You can see the psoas muscle that is originated on the lumbar vertebra, right? And at the brim, you can realize it is passing and getting attached to the femur, because the function of this psoas muscle is contraction of abdomen on the thighs. And you must have heard that the abscess in the psoas muscle will you will have issues with the flexion of the trunk on the legs when you have abscess in the psoas muscle. That causes basically pain. Now you can see this again. There is half of the image.
Kavade,
Sorry.
patient घेताय की नाही घेत?
Yes. So this is showing you the muscles of the perineum, and on one side you can also see the fascia that is covering the muscle. This obturator internus muscle, and this fascia is covering it. And this, if you see this portion where I'm moving my cursor, it is a white line of the pelvis.
Yeah.
Here you are going to have levator ani fascia pelvis and levator arcus tendinous fascia pelvis and arcus tendinous levator ani. Okay, this entire place, this entire muscle is covered with the fascia. Okay.
Yeah.
Hello, may I interrupt, sir?
The vessels of the
Yes, yes.
we have
Any
already
doubts?
covered. This is again the same image.
If anybody is having doubt,
Sir, could you please point out the psoas muscle in the laparoscopic image?
In the laparoscopic image, probably we'll be having that image. I will tell you. You can see in this image itself. You can see this brownish structure here. That is the psoas muscle. Actually, when we do laparoscopy now, the only problem is patient is lying down. So the orientation of muscle you have to understand accordingly. In standing position, you will see the psoas is going down. And in laparoscopy, when patient is lying down, you will see the muscle going up. You understand? I hope this solves your doubt.
yes.
Yes. So now you can see this nerve. I told you the two tracks.
Yeah.
This is a genitofemoral nerve. Okay. It has two roots or two branches here. One upper is a genital branch. They say if you don't want to be the enemy of patient's husband, then do not touch this nerve. Because if you touch this nerve, what is going to happen? She is going to lose all the sexual sensations. Understand? So this nerve is very, very important. Secondly, I'm sorry. You can see this nerve branch that is going lateral to the femoral artery, and it is a femoral nerve. Okay. It goes along with the femoral artery. Here you can see the nerve is lateral and vein is medial. At femoral canal, it is going to be exactly opposite. Nerve is going to be medial and vein is going to be lateral. Okay. So again, the interiliac artery we have already discussed. This is the image that is going to show you.
Lymphadenectomy or the means the lymph nodes extractions from the external iliac or the iliac point of view. At that time, most of the times this nerve get hampered. So post-op management in such patients, what we should explain her about it, or any medication that we can provide her. When we do
Like,
the
I didn't get your
lymphadenectomy
question.
from the iliac region, no? And if we heard that genitofemoral nerve,
yes.
at that time,
See,
how should we manage that patient post-operatively?
See, if you damage any nerve, the only option is repair it.
How?
Are you getting it? So
Yeah,
no medications are going to get her sensation back to the normal. The only hope that you can have is sensation from another side of the nerve. For neuropraxia, you can give medicines like neurostabilizer, pregabalin, and everything. But if you completely transect the nerve, no way you can have that nerve working again normally without repairing it.
Okay.
Understand?
Yeah.
Okay. So now, this is the video that is going to show you the posterior branches. Can you see this? These are the posterior branches of the internal iliac artery. Okay. This is the large vessel. Can you see this large branch? This is the pudendal artery.
Yeah, pudendal one. Yeah.
This is a very large artery.
Yeah.
Can you see? And this is the uterine artery. Can you make out the difference in the lumen?
Yes.
Yes. So that is how, and it is pretty deep.
Yeah.
This is the pudendal vein. You can see the size of the pudendal vein that is coming. It's huge.
Yeah.
It is a major artery and the major vein that actually supplies the organs and drains the organs. Okay. So you have to be a little careful about these vessels, especially pudendal. Any other vessel you coagulate, there is no problem. Okay.
Okay.
So now in this diagram, in this the image, you can see the obliterate umbilical artery here. Can you see this?
Yeah.
This is the vesical artery. Can you see the vesical artery? Yes.
Yeah. Yeah.
You can see this uterine artery that is crossing midline and going towards the uterus. Can you see here?
Yeah.
And from here you are going to have the ureter that is coming. I'm going to show you that also. This is going to be your middle rectal artery. Can you see this? Okay?
Yes.
Perfect. Now, all this all dissection is going to be done for the obturator artery. The obturator artery is the lateral branch of the internal iliac artery, right? And I told you it goes below the internal iliac, external iliac vein. Can you notice it? It is going below it because the fossa, that is obturator fossa, is this area. Okay. Okay. Do we have a pointer? Anyhow, I don't know how to utilize the pointer.
You have it there. You have it there. You can.
Okay, perfect. Now this is the posterior division. Can you note this little branch? This one. Can you notice this artery? This is the posterior division of the internal iliac artery.
Yeah.
Okay. And whatever branches that we see in the anterior division, this posterior division is very close to the division of the common iliac artery. Okay. So that's why we don't generally dissect it. This video is just for the demonstration purpose, and you can notice all the vessels here. You can notice everything practically. Okay.
Yeah.
And if you stop here, I'll just show you. This is the psoas here. These are the nerves. This is the external iliac artery. Internal iliac artery is not dissected yet. You can see the obliterate umbilical artery. You can see the uterine artery again. You can see the division of the internal iliac arteries. Okay. And this space here is the retrorectal space that is going to come here. That video is obviously going to come later. Okay.
We have to still talk about that spaces and all this.
Deep uterine vein. Okay. This one here. You can see the good, nicely pulsating all vascular structure. Can you see?
Can you play the video?
Pulsating very nicely. And this is one thing that I wanted to see. This is the inferior hypogastric plexus. Can you see this?
Yeah.
You can see these nerve fibers. This inferior hypogastric plexus supplies both parasympathetic and sympathetic innervations to the rectum and your cervix and bladder. Okay. So basically this is the part of the rectal pillar. Can you see these nerves are going towards the rectum? So this is the part of anterior rectal pillar. Okay.
Yes.
And this entire space is called as Okabayashi space.
It's a beautiful dissection.
This is the internal iliac vein here, right? You can see this ureter going here, and you can see this hypogastric plexus here, so very close to each other. Can you notice? This is the ureter here, and this is the retrorectal space. If you can notice, this is the coccyx. This portion, this is coccyx, right?
Okay.
This is the ureter that is passing, and this is the hypogastric nerve plexus. See, hypogastric nerve takes the parasympathetic supply from the sacrum. Can you see this nerve fiber that is coming from the sacral foramina? These nerve fibers, those are running like this. Can you see? These are all parasympathetic nerve supplies. Okay. So even if you are demonstrating, you are not supposed to ignore it. Okay, that one thing you have to be very sure about. right? Again, the same
Yes.
musculature I have denoted with this. We have seen the genitofemoral nerve, we have seen the obturator nerve, both. This is the obturator nerve, precisely in the obturator fossa. Can you see? For dissecting the obturator nerve, what we have to do? We have to dissect the external iliac, then internal iliac, external iliac artery, then vein, and just below, parallel to the external iliac vein, you are going to have this cord-like structure in the obturator fossa. Okay, and this is demarcates the basically it is used for dissection of the lymph nodes in the obturator fossa. Okay, this is the obturator. This is obturator umbilical artery. You can notice here. Now this entire place, can you see this plane? Uterine artery going here. So this entire plane is a paravesical. Okay, this fossa here below the uterine artery, lateral to the rectum, is pararectal space. Okay.
Yeah.
Again the image, you can see the ureter that is crossing and going here, and you can see the nerve fibers here. Okay. Yeah. And this vessel that you see here, can you see this vein? This vein is a deep uterine vein. Can you see here? It goes inside the internal hypogastric vein or internal iliac vein. Can you see? So very nicely seen. If suppose it has injury, it is very close to the hypogastric plexus and also the ureter. That's why coagulating this portion can be little tricky. Okay.
Yes.
Now this another image that is showing the ureteric tunnel. Can you see this? My instrument is going inside. This is the ureter, and this area probably will see in the next year. Now I would just tell you about the pelvic spaces in brief before actually showing the dissection. See, pelvic spaces you can imagine just like, or pelvis you can imagine just like an Amazon parcel. You understand? Whenever you ask for the some fragile structure to be delivered from somewhere, you are going to have that fragile structure in between, and around that you are going to have a packing. You understand? So the pelvic spaces exactly are those packings. Can you see these white fatty structures and the organs in between? These organs are the fragile things that those are there in the Amazon package, and the thermocol ball jala manto na apan. You understand, na? Those thermocol balls are these pelvic spaces. These are just to protect the organs. Okay, but these organs, these pelvic spaces, has provided a surgeon a very good avascular spaces to dissect the diseases. You understand? So what all pelvic spaces we have? We have 1, 2, 3, and 4. Okay, these are singular spaces. One is the retropubic space, or the space of Ridges, rectovaginal space, then the vesico-cervical space, rectovaginal space, and retrorectal space that I shown you right now. Then there are paired spaces also. These are the paravesical and pararectal spaces. Okay. The significance I'm going to show you next. See, this is the pararectal space. The pararectal space, if you see, this is lined by laterally, medially by the lateral wall of the rectum, laterally by the internal iliac artery. The floor is going to be formed by the pelvic floor. This is levator ani muscle that you see exactly in between. So this is the pararectal space. Now the pararectal space is again divided into two halves. One is the medial pararectal space and lateral pararectal space. So medial pararectal space is medial to the ureter, and the important thing that we have in the medial pararectal space is the inferior hypogastric nerve. That's why it is called as Okabayashi space. You must have heard this Okabayashi space a lot of times when you are doing nerve sparing radical hysterectomy. Okay, so medial and lateral is called as Latko space. Now the paravesical space, is bounded anteriorly by the pelvic, your lateral wall of the bladder, then laterally by the bone, your obturator bone. The entire fossa is going to be included in the paracervical space. but this paracervical space is divided into two by this obliterated umbilical artery into the medial and lateral paravesical space. Okay, the lateral paravesical space is a very important space because in lateral paravesical space you have this obturator nerve. This entire place that you see is the obturator fossa. This white thing that you see below that is going is the obturator bone. Okay, and if you see, this is the obturator vein that is going along with the obturator nerve and it is exiting the pelvis. And this structure that you see exactly below the obturator nerve is the obturator artery that we have already seen in the previous video. Okay, so this is the thing, and everything, the fibrofatty tissue along this entire place is the pelvic lymph nodes or the obturator lymph nodes. Okay, so clearance of this obturator lymph node is very important as far as the clearance of the disease is concerned. Okay, now the rectovaginal space is also a very important space because while doing radical hysterectomies, while doing the vaginoplasties, while doing the endometriosis diseases or the endometriotic nodule excision, you need to dissect the rectovaginal space. Without doing pararectal and rectovaginal space, you cannot relieve patient of any rectal pathology caused by the endometriosis. You have to keep this thing straight in your mind. You have to know the rectovaginal space and the pararectal space. It is very, very important. Okay, the retrorectal space and the peripheral sacral space. I have already shown you on the diagram that how does the Walder's fascia and the retrorectal space works. The only problem with the Walder's fascia, I would tell you, is the bleeders that it has, because the Walder's fascia has some veins that is coming perpendicular from the foramina, and if you touch those veins, the bleeding is tremendous. Okay, so again, this image is going to show you the ureter. You can see the inferior hypogastric nerve, and this is the retrorectal space. This retrorectal space or the presacral space is going to start from the levator plate to the sacral promontory. That entire space is called retrorectal space. For here, I have just shown you. You can see this white structure, that is the coccyx, and the entire structure that is there beyond the coccyx is the levator plate. Okay, you can see this nerve that is going towards the rectum, and you can see this nerve, those are going towards the bladder. So these are two divisions of the hypogastric nerves, inferior hypogastric plexus. Okay, so again, the same image that is showing the vicinity of the your retrorectal space and the hypogastric nerve. This is again the image that is showing this. This is the ureter. Okay, this is the uterine artery that is cut in of the uterine artery. It is supposed to cover the ureter to form the water under the bridge. There is one more space that is important again in the cases of radical hysterectomies, and that is a Yabuki space. Okay, so Yabuki space, I will show you on the image straight away. This is the Yabuki space. This is the uterine artery. You can see the ureter that is crossing the uterine artery and coming out here. Can you notice? This is the ureter. This is the uterine artery. This is the lateral border of the cervix, this area. And this place is called as Yabuki space. Why this place is important? This place is important because here is the place where hypogastric nerves are going to enter inside the bladder and your bladder trigon. Okay, so that's why this space is important. Once you cut the uterine artery here, uterine artery on the origin, you reflect the entire uterine artery medially. You cut the what we call, just now you can see this is the place of pubocervical ligament. Can you notice this fascia thing? I told you right now. And the thing that is underneath here is the ureteric tunnel. This, what you see here, is the roof of ureteric tunnel. Understand? And this is all fascia, nothing else. This is going to be the cervical ring where this fascia is connected. This portion, if you see the cut end, that is dissected already. Otherwise, this entire thing is covered like this from here. Understood? So this is a Yabuki space, and this is water under the bridge phenomena of ureter. Right?
Yeah.
Now again, this is the dissection of pelvic lateral wall. You can see the psoas muscle, and immediately once the psoas muscle is there, you can see it intact. There are no two branches of the now you see the entire genitofemoral nerve.
Audio is not there, sir. Audio.
When you hold the IP ligament and pull it medially, immediately you are going to see a structure, and that is ureter. Okay, there is no excuse for this. Basically, if you need to do the difficult gynecological study, you can see a V, the triangular structure. You can see the external iliac arteries. You can see the IP ligament digging there. Once you start digging there, you realize you find the ureter on the medial aspect of that fold, and on the apex you see the uterine artery. Okay, it is relatively easy, because I told you it is these are the spaces created by the God only for the laparoscopic surgeons. Okay, and it makes your life so easy. I'm telling you, because if this spaces would have been vasculated, a lot of vascularity would have been there, the dissection in spaces would have been difficult. But obviously, in cases of redo endometriosis cases, or in cases of fistulas, you have a lot of neovascularization in this area. So dissection becomes difficult because of the scarring and also because of the neovascularization. Can you notice? You can see this ureter here, and you can see the vessel. Okay, this is obliterated umbilical artery, and you can see this vessel that is going to come up very shortly in 2 minutes. So this space that is there is a pararectal space. Okay, in the space inferior is a pararectal space, and the pararectal space has a content that is ureter. Okay, and the vessel that is going to be dissected, the vessel that you see right now, and is uterine artery, and you can see the ureter passing underneath. Okay, so it is a water under the bridge, and this area is a paravesical space. The area above is called paravesical space, and you can see this vessel. You'll see in 1 minute, and that is a vesical artery. Okay.
Yeah.
You can see this here.
Yeah.
Sorry, where's the marker? Here. Okay. The paravesical artery. Right?
Yeah.
And paravesical space, and what is the core of the paravesical space? Is the levator ani muscle. If you keep dissecting here, in no time you are going to reach the pelvic floor. You can see a vein just below the uterine artery. Can you see that vein? That is a superficial uterine vein. Can you notice? Can you notice that vein? It is a superficial uterine vein. Okay. You can see the length of the uterine vein, uterine artery that is going to be there. You can coagulate the uterine artery wherever you want. Okay. This section is very important, even if you are doing the myomectomy cases, or the probably you are doing scarectomy cases, or any cases where in the pelvis, or anything that is related to the uterus, where you want to reduce the vasculature, you need to dissect this space and coagulate the uterine artery the way I did right now. It's a very simple procedure, but very effective one. You can see the ureter that is going underneath. Okay.
Yeah.
One more thing I would like to tell you guys is these spaces, even if they are called spaces, they are not spaces, they are created spaces. Okay. You are holding and lifting the peritoneum, that's how that space is being created. Otherwise, everything is just stuck together. Understand? So
Yeah.
if you cut something, if you dissect something, you need to hold it up with the appropriate traction to identify the spaces properly. This is the IP ligament that I'm cutting right now. Okay, coagulating and cutting. You can see once you come near the brim, you can see how close the ureter is going to be to the IP ligament. Okay, so whenever you are trying to coagulate the IP ligament, it is must that you must also dissect the ureter away from the IP ligament. And the place that you see right now is the ureteric tunnel. I've shown you in the previous images. Just underneath the uterine artery, you see the IP ligament. You can see the dissection of the ureter and the uterine artery on the other side. Again, the similar thing is going to happen. You are going to dissect first in the pararectal space. Once you identify the ureter, you hold the IP ligament medially. the space that you are going to dissect is the pararectal space always. Understood? There is no option to that, right? And you have n number of options for dissecting. You can identify the obturated umbilical artery and then come down and find the uterine artery. You can directly go into the pararectal space and try to dissect the ureter medially, and you find a vessel that is crossing. There are n number of ways. You can choose your way the way you want. There is no problem at all. This is the area you are going to have a hypogastric nerve here. Okay. Probably in this dissection, see it. Okay. This is the internal iliac vein. That is a continuation of the pudendal vein here. Okay. And this, you'll see it. The white structure that you see is a hypogastric nerve. Can you see it nicely? It is a inferior hypogastric plexus here. It is approximately 1.1 to 1.5 centimeter below the ureter. Okay. And it is a 𝘋𝙀 space again. Right. So you have to identify all the structures before removing the parametrium and paracervical tissue. And you can see this uterine that is crossing the midline. So only one way that crosses the midline is uterine. So there is hardly, and believe me, the vasculature or vascular anatomy, or not vascular, but the arterial anatomy of the pelvis is 99.99% times it is going to be the same, except the venous anatomy, because venous anatomy has a lot of variations. So you imagine the number of permutation and combination you can have that. You can see the deep uterine vein coming here. You can see this deep uterine vein below the ureter, and it is getting connected to the obturator. Can you see this one?
Yeah. Now we can see.
You can notice it, right? So it is going inside the pudendal vein, and then it continues as the internal iliac artery. You can see the entire uterine.
Sir?
Yes.
Can you share these videos for us? Means
Absolutely.
what happens now, due to the lack of time, we can't see your dissection properly. So if possible,
Yes.
if you can share with us,
So
absolutely.
No problem. You can see again, this is the dissection of the lymph nodes. I told you, this is the obturator nerve. Entire obturator fossa is clear of the lymph nodes. Can you see it? This is the obliterated umbilical artery. You can see the obturator internus muscle also here.
Yeah.
Can you notice?
Yeah.
Internus muscle. The artery, you can see the obturator vein, right? This entire the fibrofatty tissue is cleared from here. This was the case of CA endometrium actually, where we were dissecting all these things. Okay.
Yeah.
So you were asking about damage of the nerve, right?
Yeah.
So you cannot afford the damage of the obturator.
Sir, I want to ask one question. Sir, excuse me, sir. I want to ask one question. Can we take a patient of CA endometrium for laparoscopic radical hysterectomy? Is it advisable?
Absolutely, you can take it, sir. Yes.
Okay. I had seen some literatures.
We can do the. See, actually, if given an option about between the CA endometrium, CA cervix, and CA ovary, I would say the CA endometrium is going to be the safest patient that can be taken for laparoscopic radical hysterectomy.
Yeah. But we need uterine manipulations.
I think about the laparotomy, I think. What do you say, sir?
No, sorry. In CA endometrium, we do not put the manipulator inside the uterus. The manipulation is done from the abdominal end only. In fact, in all the cases of the CAs, we don't do the uterine manipulation from down.
Yeah. That's what I'm asking, sir. So we can take CA endometrium.
You can see.
Please continue. Okay.
Yeah, due to some network issue, I think.
Yes. Again, this is the dissection of the obturator.
Hello, Dr. Pawan. Can you hear us?
Is it? Yes. Yes, absolutely.
Yeah. You are not audible. That's why.
Again, on the other side, we are dissecting the entire obturator fossa. Okay. And that's it. Yes.
Any questions from the audience if you have? Dr. Sujit?
So you can ask as many questions as possible.
Yes.
So that
He is
I
a
would
very
love to
good
answer
teacher,
them.
means asking the questions, he loved it.
No, it's very nice
Anytime.
I can explain better when somebody is asking questions. Dr. Priyanka
Yeah,
will
yeah.
agree.
Please tell us the limit of dissection in radical hysterectomy. What are the limits?
That was the limit. See, whenever you are doing pelvic lymph node dissections in the radical
Anatomical
hysterectomy,
limit, anatomical landmarks and anatomical dissection. That is the
yes. So this is the limit. When you see this nerve exiting the pelvis,
yeah,
that is the limit of dissection. You cannot go beyond that. There is no need to go beyond that.
yes.
So once that much is achieved, your pelvic lymph node dissection is over.
Yeah.
Okay.
Is it necessary to dissect till the common iliac?
Sir, it totally depends upon what stage of the disease we are dealing with. If suppose we have a clear cell disease which is aggressive, then we might have to dissect the para-aortic lymph nodes also.
Okay. But what do you prefer?
Sorry?
What do you prefer?
If suppose patient comes in the early stage, then dissection up to the inter-iliac lymph nodes is enough.
Sir, I want to ask one question. In CA ovaries, we have to do omentectomy.
Yes.
But how it is possible? How it is possible in the laparoscopy?
No, sir. In CA ovary, I will not do laparoscopic hysterectomies. Laparoscopic radical hysterectomies. For CA ovary, obviously we have to open the patient.
Yes. For CA endometrium, CA cervix, I think CA cervix.
CA cervix can also be operated. I think laparotomy will be the better approach than laparoscopy. What do you say, sir?
Actually, I differ in that. There are so many people who says that, but then I feel the laparoscopy is a better approach for doing the CA cervix also, because
at what stage you will prefer that? Means with the early stage.
If you have an operable patient where you are having a CA cervix at stage 2A, till then you can operate the patient with the laparoscopy. There is no problem.
Yeah, that's
because
what
sometimes what happens, we do get a surprises on examination. We see that the patient is CA cervix probably 1B or 2A, and when we enter inside the abdomen while dissecting, you realize that some portion of the paracervical tissue is also involved. So practically it becomes 2B.
Yeah.
But then even in that cases, dissection of the nerve and the parametrium, it becomes easier for me. At least it becomes easier while doing laparoscopically.
Dr. Shailendra, can you unmute Dr. Musawe, sir? He want to ask something.
Yeah. I want to ask one question, sir. In CA cervix, how could we get clear margins or the free margins if you are doing laparoscopically?
Sir, we can definitely get free margins. The tissue field is like that. In normal cases, what happens? The fat that we see is absolutely free.
Absolutely, we can get free margins in laparoscopy.
You mean to say without any histopathological findings, which means frozen sections and all?
Yeah. After HP report, if there are no free margins, then it's difficult, na? We have dissected macroscopic disease, but what about microscopic disease?
Sir, that is going to be the problem with the open surgery also.
Yeah.
In open surgery, we can extend, we can get free margins also. We can get more cuff of the vagina.
Sir, in laparoscopy also we can absolutely. Sir, in laparoscopy, we generally spare the approximately 1 centimeter, at least 1 centimeter margin of the vagina when doing the laparoscopic resection or open resection. The technique is going to be same, sir.
I think with
Sir,
laparoscopy
the
also we can do the para-aortic till the para-aortic dissection.
Yes,
So
yes, absolutely. We can
dissection
we
is
can
not
do
the
till
part.
the-
Yeah.
So it
He is
totally
not-
depends upon the experience of the person. Because see, thing is
Yeah.
that when you know what tissue is normal and what tissue is not,
Yeah.
and once
Yes,
you
yes, yes.
identify
Sir, we
that,
have-
you can achieve the.
Sir, we have one question from respected Musade sir.
Yes, sir.
What precaution should be taken during bladder dissection?
Bladder dissection in normal cases.
In every case, maybe in sir might asking about this CSF.
You can unmute him, na? You can unmute him and let him to ask in which conditions he want to want.
Okay. I will.
Unmute him.
No, Pradeep Musade sir is already unmuted.
Okay.
Yes.
Sir, please ask.
Yes. If there is a previous scar on uterus, then if you want to dissect during TLH and all this, then what precaution should be taken during
Sir,
TLH?
suppose you have a previous cesarean section patient. So we
Yes,
do expect bladder adhesions, right?
yeah.
So in doing a bladder dissection, what I follow is a lateral window technique.
Okay.
What I do the
Dr.
posterior
Shades space only. Okay.
Yes.
Hello?
So what I do, I dissect the posterior peritoneum first.
Okay.
After dissecting the round ligament, I dissect the peritoneum over the bladder,
Okay.
identify the uterine,
Mhm.
and dissect the plane between the uterine artery
Sir,
and
in
the
recent time, we are getting.
Hello.
Yeah.
Sir, in recent time, we are getting more and more cases of ventrofixed uterus because the
Yes.
cesarean section that has been increased and the
Yes,
cesarean
yes.
section it is done in and remote places also. So the incidence of ventrofixed
Yes.
uterus is become more. What I practice, what I feel.
Yes.
So again, bladder dissection, as Musade sir asked, bladder dissection again it is going to be a issue. Then please elaborate on this.
Sir, actually, what happens whenever we have a ventrofixed uterus? What I generally do, there are two kinds of ventrofixed uterus. When whatever I could understand from multiple cases that we do, when entire round ligament is also adherent to the anterior-abdominal wall, and sometimes we find the patients where there is only one single band that is going from the anterior wall of the uterus to the anterior-abdominal wall.
Okay.
No, uterus is totally matted to anterior abdomen.
Absolutely, sir. So what in these cases we do is we identify the round ligament.
Yeah.
We hold the round ligament, pull it down, and start dissecting from there. We create a space between the round ligament and the peritoneum, and from there we keep on digging in that plane. Once you identify the round ligament and you go towards the uterus, you will find the uterine artery. And believe me, sir, even if you have adhesions on the uterus, the lateral aspect of the broad ligament is going to be free of adhesions. Once you identify the uterine artery, again the same thing is going to be done. And in this case, in ventrofixed patients specifically, I do retrograde dissection. I first go down and dissect the bladder first, and then once the bladder is dissected, I come up. Because most of the time, what happens when you are trying to dissect the ventrofixed uterus and start from the fundus, you don't realize what tissue next is going to come to you. So that tissue can be bladder also.
Yeah.
So if you do the retrograde dissection, your bladder is totally dissected down, and once you come towards the fundus, your dissection becomes easier.
What if you injure bladder pillar or the veins while dissecting the paravesical spaces?
Sir, nothing happens. You can just coagulate it.
So,
see, the one thing we have to understand, one thing in this is very important, that even if there is a bladder dissection, bladder adhesions, even if there is a ventrofixed uterus, the trigone of the bladder is not going to change.
Yeah.
Even if we are doing cesarean section, we are causing a lot of adhesions in whatever manner we do. If the adhesions are there, trigone and the ureteric position is going to be the same in ventrofixed uterus. Understood? So even if we are dissecting that portion, that doesn't mean we are going to cause any injury to the ureter or the nerve fibers or the vein of the bladder, or the paravesical plexus, I suppose you are asking. It is not going to cause any problem there.
Okay. You elaborated very nicely, sir.
So generally, we means afraid to go retroperitoneal dissections, So how should we practice it? Means how we should get the confidence in retroperitoneal dissection?
See, thing is that the most important thing that we are scared about is darkness. We are scared of darkness because we cannot see what is there. We don't know what is there, right?
Yeah.
So in lateral pelvic wall dissection also same thing happens. If you don't know what is there, you are going to be scared of it. So better you know the pelvic anatomy, and if you know the pelvic anatomy, automatically the fear that you are going to have of dissection of the lateral pelvic wall goes off. And plus, I would suggest you to see all the videos that those are there. See, if you can put in a trocar, then you can do dissections.
Yeah.
The most important thing in doing laparoscopy is putting a trocar. If you can do that, everything else can be done.
Yeah. Any questions from the audience? Dr. Sujit?
Hello.
Shailendra?
Hello.
Yeah.
Yes, sir. Please, madam, ask question.
Sir, as I'm the junior and I'm not dealing now with the laparoscopic surgery, I'm only dealing with the C-section and all. So I want to ask question about the C-section or anatomy during the section. May I ask?
Okay, madam, please. Yes, please.
Please proceed.
While delivering the fetal head or while stretching the uterine incision, so what precautions should we do to avoid the uterine artery ruptures? Because 2 days back, I have dealt with the big hematoma of the uterine artery while stretching or while delivering. We don't know whether it is already present or it is created after the delivering the head or during stretching of the uterine incision. So what precautions we should have?
See, first of all, I would tell you, see, most of the cesarean section, I don't know whether it is elective or emergency cesarean section. The problem comes when you are dealing with the patient in labor. Whenever head comes in the lower uterine segment and you give a small incision, you try to stretch the uterine lower uterine segment. The problem is lower uterine segment is soft now by the time the head comes down. So the tearing of the lower uterine segment is going to be higher. So what I do personally, I give a smiling incision on the uterus. And the incision is not smaller. What traditionally we do, I'll just explain you on the screen. Okay. So if this is the uterus, generally what people do, they give this much incision and then try to stretch it. Understood?
Yeah.
What I do, your uterines are going to be here. What I do, I give with the knife, I give an incision like this. Understood? So even if it has to tear, it will tear in this direction.
Right? Madam, we had one webinar on the delivering fetal head during C-section.
Yeah.
In that webinar, everything was explained. Some videos are also there. You can see it into YouTube also. Priyanka Nakade madam will provide you link.
Yes, sir, definitely.
Okay. Any next questions? Okay. So
I suppose
Dr. Sujit
everybody has understood everything.
Yeah. Yes, sir.
I suppose everybody has
Dr.
understood
Sujit.
whatever I thought.
Hello, Patradhankar.
Yes.
There is problem with my network. You can conclude if you want.
Please ask your questions if you have.
No, I have asked.
Okay. Please go ahead, sir.
Yes. So now I just want to share a link. I discussed with Dr. Priyanka also, and just hold on.
If you have any queries regarding this session, you can put these queries in that.
Yes, absolutely.
So we want to see that video, sir.
What video, ma'am?
Now you have already shared, but we cannot proceed due to the network issues, no? So the
iliac node dissection, parietal spaces,
everything that you have already shown to us, no? But we can't see it properly.
Yeah, there was disturbance because of the network.
Yeah. That's why I'm telling you that again you can share with us and we can see that properly.
Sure, I'll do that.
Yeah.
Yes, I am just sharing you the link of a group, okay, that we have created, so that we can have discussions about the. This is not a one-time thing that we have. It is going to be a continuous process of learning. That's what I believe, and I have created a link of the WhatsApp group where we can share the knowledge, we can share the queries that we have, any doubt we have, and everybody, probably the seniors and everyone who has the knowledge of it can solve it. Okay, so we wanted a video, right? I'm just going to share you the
we need that videos to get shared with us so that we can see that properly. Everybody.
Now is it clear?
It's clear, but somehow due to network issues, now we can't see it properly. Properly run nahi ho pa rahe videos, they get stopped.
There is some network. What?
So what you can do,
what I'm going to do, I'm going to share this video on.
You can share it on the group,
on the WhatsApp group if it is possible.
Yeah. You can share it, and if anybody is having problem or if they want any discussion regarding this topic, they can directly ask the questions on that group, and sir will answer definitely.
Yes, absolutely.
Hello?
No problem.
Okay.
Yes, sir.
Can I have a vote of thanks?
Yeah.
Absolutely.
Is it finished?
Yeah.
Okay. It's very nice session. Gulane sir has described each and every point in the pelvic anatomy. Sir, I wanted to say something.
Yes, sir.
In the history of anatomy, Sushruta is he has very great contribution in elaborating the anatomy. He is the only person in ancient time who had done cadaveric dissection.
Yes.
To know the exact anatomy. Actually, in the modern science, cadaveric dissection has been started in 15th and 16th century. It's too late. But we people, our Sushruta is very well versed with the anatomy. And I think it is a bold statement that you should not hold a knife before knowing a good anatomy.
Absolutely.
Yes.
Yeah. This is the message you have elaborated very nicely, sir. Thank you, sir, for being with us. Is it okay, Priyanka?
Yeah, it was wonderful session, sir. To the mark, and I would like to say thanks from all NEMA OBGYN Society that you have delivered such a knowledgeable session today, and we absolutely want to see you again. Means part 2 of this session will, I think, we will demand, and other subjects also we would like your guidance for that purpose. So I think, yeah.
We have a Facebook live channel also where we keep on doing the laparoscopic surgeries, where a lot of new surgeries, new technique that we follow.
Yeah.
A simpler technique, complicated cases where we use our techniques where things become a little easier. So
yes.
You all can join that group also. There is no problem at all. Dr. Priyanka can share you the link of that group also.
Yeah, definitely. It's a very good opportunity for the budding gynecologists also. They can learn so many things from him, And I would like to share that links with you people also, and so that you can see that videos, and there he will teach you some key points during the laparoscopy. So definitely I will share it in the group so that all will get benefited. Thank you so much, sir. Thank you so much for being here with us.
Thank you.
Thank you, sir. I will request Kiran Soni ma'am, please call up the meeting because you are now host. Hello, Kiran Soni ma'am.
Good evening.
Hello.
Hello.
Hello, ma'am. Please. If you want to say something, you can say and call off the meeting.
It was a very wonderful session, sir. I have listened. I have seen all your sessions previously also.
Thank you, ma'am.
Thank you, sir. Thank you very much for giving this opportunity कि हम आपको सुन सके और अच्छे से लर्न कर सके.
Thank you so much for inviting entire NEMA society. I'm always like blessed with the actually Dr. Priyanka always says that she is a student. Actually, she is not a student. She keeps on teaching so many things to me.
No, not at all.
So thank you so much, guys, for
I'm
having
blessed
me.
with your guidance, I should say, and I openly said that I'm really proud of you. I'm really proud to say that you are my guru.
Thank you so much, ma'am.
Yeah. So we can conclude this session.
Yes, absolutely. Thank you.
Yeah.
Yes,
Thank you so much.
Absolutely.
Yeah.
Then